Hello, I think we are waiting for Dr. Arvind Panda to join.
Yes, madam.
Then we, yeah, sure. So you have my presentation with you now because I told you.
Yes, madam. Yes, madam.
Yeah. Yeah.
Dr. Panda sir is here.
Hi, Arvind.
Hello.
Hi, Arvind.
Can you hear me? Hello. Hello.
Hello. Yeah, we can hear you.
Hello. Can we start, madam?
Yeah, of course we can start.
Yes, ma'am. It's my privilege today to be introducing Dr. Sujata Patwardhan. She is the head of department of King George Medical College Hospital and the KM Hospital in Mumbai. And she is also I consider her my teacher, and it is my privilege today to be introducing her here. She will be speaking on a topic very close to her heart. And the topic is intraoperative consult for urinary tract injuries. She has done extensive work on this and has presented also excellent oration on this very recently. So I think she's someone who doesn't have to be introduced. She's so well known. Over to you, madam. We are eager to hear this.
Okay, yeah, sure. I think. Can you please start sharing the presentation? Thanks, Arvind.
Thank you, madam.
Yeah, so today's topic is intraoperative consultation for genitourinary injuries. And we'll be presenting our experience. I would be covering a bit of the theoretical part because there are students in the, however, intention is to show you different cases and take you through practically different situations which we have faced, and it was possible for us to record in the just recent few months. First slide, please. Next slide, please. Yeah. So genitourinary, though the incidence is just for us, they form a majority of intraoperative consultations. Etiology is usually trauma and iatrogenic. So these are the two basic headings under which all the injuries occur. Next slide. Renal injuries are the most common type of genitourinary injuries, accounting for 3.2%, and most common cause being blunt trauma. In addition, we have ureteric injuries and bladder injuries, which are the most common causes for intraoperative consults, because renal injuries come to us directly, or very rarely we are called as a part of when the surgical team is for some other injury. So upper ureteric injuries are mainly iatrogenic, and 50% of them occur during gynecological surgeries, and rest of them are during general surgical and urological surgeries. Bladder injuries are also mainly iatrogenic, and a few of them, that is 1.6% of the bladder blunt abdominal trauma associated with fracture pelvis, may be associated with bladder injuries. Next slide, please. Urethral injuries is the second most common. These are not our topic today because we are dealing with consultation. And scrotal injuries result mainly from blunt trauma, athletic activities, and they can result from simple bruising through hematocele to overt testicular rupture. Penile fracture is also relatively uncommon and occurs due to excessive bending of the erect penis during intercourse. Slide. Next slide, please. So I will be covering all these topics, which will be requiring only acute intraoperative consultation. So we have seen that this is a slide which is telling you an overall view of the etiology of injury. And in kidney, you can see in kidney, it is mainly due to blunt and penetrating trauma, and iatrogenic is very less likely, while in the ureter, majority of the injury is due to iatrogenic causes. Similarly, for the bladder, for the urethra, again, it shifts back to blunt trauma and penetrating trauma. Urethra, bladder, the testes is again due to blunt trauma and penetrating trauma, and iatrogenic injuries are almost nil, and penis is due to blunt trauma and penetrating trauma. We have also included vaginal injuries here, which are mainly due to blunt trauma, and iatrogenic will account only for 5% of cases. Next slide, please. Next slide, please. So a bit of the theory part I'm just taking just because we have a few students in the group, and actually I don't need to cover because this is included in your routine reading, and it is classified as to grade 1 to 5, and we know that grade 1 is just microscopic or gross hematuria, and grade 2 is subcapsular and non-expanding parenchymal injury, and grade 5 is the worst in the list, and it is associated with avulsion of the renal hilum or injury to the renal vessels. So the theory part, I won't bore you because all of you can read it, and it's very well written in all our textbooks. So the main management of renal injury has shifted from exploration to non-operative management in majority of cases, as the majority of cases fall between grade 1 to 3 and 4 maximum. Grade 5 injury is very rarely seen. So non-operative management is the main option or the main management which we use for renal trauma. And after taking care of the airway, breathing, and circulation, and if the patient is hemodynamically stable, then all grade 1 to 3 renal injuries are managed by non-operative management. And they about 55% of the stab injuries and 24% of the gunshot injuries also can be managed non-operatively. Next slide, please. Next slide, please. So it would include admission and monitoring of the vitals, bed rest until the gross hematuria resolves, and if the hematuria recurs, then again it will require bed rest and proper HB monitoring. If there is persistent bleeding or if there is delayed bleeding, which is life-threatening, then we can go ahead for embolization. Repeat imaging is advocated in grade 3 and 4 injuries, as they may worse with time or may be clubbed with devascularization of tissue and may require further intervention. Ureteric stent and percutaneous drains are the only management which nowadays we do, and it can be done even at a little later time of the injury and not necessarily be done immediately. And it can be titrated as per the patient and situation. Next slide. So apart from this routine measures which we do, there are a few absolute indications where an exploration is mandated, and this would be a hemodynamically unstable patient in shock, expanding or pulsatile renal hematoma, suspected renal and uretropelvic junction disruption. Relative indications for exploration are urinary extravasation when there is significant renal parenchymal devascularization, or then when the renal injury is associated with other colonic, pancreatic, liver, or splenic injuries, or sometimes when there is a delayed diagnosis of arterial injury. Next slide, please. So what are the principles of renal reconstruction is obviously if it is clubbed with a general surgery, they would usually take a midline incision. For us, we can either go ahead with a renal lateral incision or a midline incision, whichever is possible. Then temporary vascular control needs to be achieved. Debridement of all non-viable tissues should be done. Hemostasis of by individual suture ligation of the bleeding vessels from the parenchyma. Watertight closure of the PC system if it is found to be open. And because the patient is in shock, many times this can be missed as there may be no urine output. Then reapproximation of the parenchymal defect covering with either adipose tissue or whatever is available in the vicinity, and obviously liberal use of drains because we need to know what is happening in the postoperative period. Next slide, please. So now we start with our case presentations for renal injury. We have a 17-year-old male with history of RTA presented with flank pain in the on the right side. Hematuria single episode. He was hemodynamically stable. HP is 8.6. Next slide will show us the CECT. Next slide, please. So this patient had a liver laceration and a renal laceration or a renal fracture and having a hematoma in relation to the upper pole and mid pole of the kidney. Next slide. So this is the most common type of injury, and it can be managed just by observation and keeping a watch and the usual general precautions which I mentioned in the last few slides. Obviously, you can club it with antibiotics, and if the patient doesn't settle in a period of 2 or 3 days, then you can do a repeat imaging and see whether there is anything more to be done, any DJ stenting to be required or a drain to be placed, depending on the vitals and whether the patient has fever and sepsis and other associated injuries are also settling down or not. Next slide. This is another CT scan of a 48-year-old male with history of road traffic accident. He had no hematuria and he was hemodynamically stable. He had only tenderness. Slide, please. I think it's a video. Next slide. Yeah, can you please play it? So here the left side, the mid pole and the lower pole were not perfused, and you could see them as that there is no perfusion of, there was no uptake of contrast in this part of the kidney. So such patients need to be kept a watch on because we are not sure whether that part would necrose off and it would there would be an urinary leak And so a repeat imaging after 2 or 3 days or 4 days is indicated. And then you can take up the management from there. So putting up a drain or putting up a PCN or whatever management is required will be depending upon the further progress of the patient. Next slide. Next slide, please. This is another renal trauma. There is history, 25-year-old male with history of fall of a cement bag. So this is not a road traffic accident. This is a blunt trauma. No history of hematuria. He is a known alcoholic and tobacco chewer since last 10 years. And he's vitally, he's stable. And his creatinine is normal. HB is 9.1. Next slide. So this patient had additional pancreatic injury, though the CT is not very clear, and being the slides cramped into one, this thing, you cannot be very clearly seeing it, but there is here injury to the lower pole of the kidney, and here it was reported as having pancreatic contusion. So when the pancreas is injured, we always know that there could be delayed secretion of pancreatic enzymes in the vicinity, and there may be lysis of tissues. So such patients need to be kept a watch on, and further imaging is mandated. Next slide. Yeah, next slide, please. Next slide. So here we have a 28-year-old male who presented with left flank pain for the last 3 years, dull aching and intermittent, and radiating to groin. So from this history, we probably know that he could either have a stone disease, or he could have something like a PUJ or something going on, something urological going on. So he had history of painful hematuria and passage of blood after trivial trauma. His vitals were stable, creat was normal. Next slide, please. So this plain CT scan shows us that he has a left renal calculus, and following the trivial trauma, he has extravasation of urine in the perirenal space. So here we manage this patient by putting a pigtail, and then later on dealt with the stone. Next slide, please. Next slide. Next slide. So we also need to keep it in mind that the kidneys may be ectopically placed, or they may have some basic anomaly, or they may have some previous problems, or they could be having a PUJ, or it could be a horseshoe kidney, or something can be happening beyond the normal kidneys. So these things need to be kept in mind when we are dealing with renal trauma. Coming to ureteric injuries, again, I would just cover the theoretical part very briefly and just up to the point where it is necessary. So common sites of injuries are at the pelvic brim, bifurcation of the iliac artery, common iliac artery into external and internal iliac, lateral pelvic wall above the ureterosacral ligament, base of the broad ligament, then also the intramural portion of the ureter while it is inserting into the trigone, and upper vagina. So ureteric injuries, as we know, are more common in females and more common during obstetric and gynecological surgeries. Next slide, please. So they are also classified by the American Association of Surgeons for abdominal trauma, and they are classified again into grade 1 to 5. And they grade 1 is just a contusion or hematoma. Grade 3 is when there is 50% of the lumen is transacted. Grade 2 is less than 50%. Grade 3 is more than 50%. Grade 4 is complete transaction and devascularization, and grade 5 is avulsion. So now, next slide, please. So the management of ureteric injuries is relatively very simple, and all of us have done it on a daily basis, and I think it's relatively very simple and easy. If it is obvious in the intraoperative period and you are able to see leakage of urine, or you have realized that there is you have created an injury or someone else has created an injury, then depending upon the grade of injury, if it is a minor injury, all you need is a urethral stent and follow up at 6 weeks to see if everything is normal. If it is a major injury, then depending upon the location, we can you can decide what to do. If it is upper ureteric injury, and if need be, we cannot do a um, anastomosis back to the PUJ, then maybe we have to think of ureterocalicostomy also. In the middle part, end-to-end anastomosis, psoas H Bovary flap, and in the distal part, ureteric reimplantation. Next slide, please. Ureteric injuries need to be followed up in by a delayed imaging, so that we need to know whether our repair has not created any other problems like a silent ureteric stricture, which can result in non-functioning in the long term. Next slide, please. So these are slides from Campbell, which we are showing end-to-end anastomosis over a stent and a spatulated anastomosis in opposite directions. The ureter needs to be spatulated. Next slide, please. Upper ureteric injuries, ureterostomy, extensive loss can also be dealt with renal autotransplant or bowel replacement of the ureter. We'll be showing you in subsequent videos. Next slide. Transureterostomy is also an option which can be utilized when the opposite side is normal. And ureteroileal interposition or ileal ureter is the last option when a very last segment of the ureter has to be is injured, or it is avulsed, or it cannot be utilized for any other reason. I am not aware whether a buccal mucosa has been utilized for ureteric injuries when there is a loss of the ureter, but it has come in a big way in the management of ureteric strictures and delayed management of ureteric injuries. In the acute setting, I'm not aware as such of anything done in this matter. Next slide, please. So these are our routine. This is a psoas H and a Bovary flap. Just diagrammatic representations. All of you must have seen these things in real life. Next slide, please. Next slide, please. So at times, you would have to go ahead for urinary diversion when there is no possibility of repair, or doing a repair is not technically feasible. The tissues are not proper to go ahead with primary repair, or the patient is unstable, or patient is in sepsis. Then it is best to divert the urine from the bladder or the kidney and then come back at a later date and go ahead with the repair at a later date. Next slide, please. Next slide, please. We'll come to this back later on. Next slide, please. Next slide. So an ileal conduit also can be done when in an acute setting, if need be, when the lower ends of the ureter, if both of them are damaged beyond, like especially in cases of retroperitoneal fibrosis, sometimes it's just not possible and the ureter gets devascularized or injured beyond any repair, because sometimes these cases are really bad, and then sometimes it is best to just divert the urine by stoma and come back on a later date, or undivert at a later date. Next slide, please. Next, this is a case of a Vardheim cystectomy in a 62-year-old female who was to be done by laparoscopic surgery, and the call is received intraoperatively. There was difficult dissection and the ureteric injury has been identified. Next slide. So the mode of injury needs to be known. It could be due to cautery, it could be due to a clean cut, or it could be due to crushing of the tissues, because all this, the mode of injury will definitely play a role in the management. And especially you need to be careful about cautery burns and crush injuries. Next slide, please. The cut margins, if they are clean cut and they're bleeding, all you need to do is suture it. So in this case, next slide. Next is a video, I think. Next slide. Yeah, this is a video. Please play it. So this was an injury in this laparoscopic Vardheim cystectomy, and all we needed to do was to place a DJ stent and close the ureteric injury by intermittent sutures. Next slide. You can see that the ureter is almost 50% of the ureter has been injured. So this classifies as grade 3. This is a case of a giant cervical fibroid, 45 years old female patient complaining of abnormal uterine bleeding and posted for total abdominal hysterectomy. Call received intraoperatively. Next video. No, sorry, this is not a video. Here we could clearly see that the ureter had been clamped. Next slide. And the lower part of the ureter was totally clamped and cut and crushed. And therefore, you can also see quite a big 5 centimeters or so of the ureter is devoid of his blood supply. But he could manage this patient with reimplantation. Next slide. Yes, so I covered this while speaking on the slides. Next slide. Yeah, please play the video. This is an intraoperative. This is actually this video is not very clear, but it was an intraoperative call where there was a lot of inflamed tissue in relation to the ureter. And during dissection, after we started dissecting that area where the ureter has been injured, we found out that there was the ureter was diseased, and that part was, I hope you can appreciate it. It's not very well. No, this is the reimplantation going on. The next video will show you is what I was talking about. Yeah, this patient, 51-year-old female patient posted for laparoscopic hysterectomy. Call received intraoperatively, dense adhesions and difficult dissection of the lateral pedicle. Next slide. So here once we, can you show the next slide, please? Here, when in the intraoperative period, you can see that the entire ureter has been denuded, and it is not having any vascularity. So it was a case of ureteric avulsion. So we decided to go ahead with ileal ureter. Next slide. So we isolated a segment of the ileum depending upon the length of the ureter, which had to be bridged. And you can see that end-to-end anastomosis is done, and a big segment, almost 15 centimeters, has been isolated on his pedicle. Next slide. Then the ileum has to be trimmed so that it fits snugly over an 8 to 10 French infant feeding tube. Now this can be done by cutting the ileum. It can also be done by use of Vicryl staplers, or you can use the methods which we use for imbrication of the ureter, mega ureter, and the same methods can be utilized to narrow the segment of the ileum so that it is approximately 8 to 10 French in size. Next slide. In this surgery, we have just sutured, we have cut the excess of ileum and sutured it. And then the lower end is fixed up into the bladder and the upper end into the upper ureter. Next slide. But recently we have tried the use of staplers for this procedure. And obviously you can't use metal staplers. You will have to use Vicryl staplers because metal staplers in contact with urine would result in stone formation. Next slide. So this is the lower end of the ureter being placed in the of the ileum placed in the bladder. Next slide. Yeah, next slide. Yeah, so this was the case I was referring to just a few minutes ago. 40-year-old female, abdominal hysterectomy for fibroid uterus, intraoperatively prolonged surgery, but no history of hemorrhage, no transfusion. Patient was on per-urethral catheter. And on day 2, she had per-vaginal copious discharge and had fever with chills, pus discharge from the pelvic drain. And here, so we decided to explore her because in the ideally during if the injury is clean cut and there is vaginal discharge and we suspect that there is either a VVF or a UVF, the common teaching is to wait and allow the tissues to stabilize for a period of 6 to 8 weeks. If it is a vesicovaginal fistula, if it is a uretrovaginal fistula, we may put in a stent or put in a PCN. And usually we don't go ahead and explore immediately. But if the patient is in sepsis and there is pus discharge and there is fever, then we have no other option but to go and explore. Next slide. Yes, so possible etiologies could be varied. We just only think of the ureter and bladder, but it could be other neighboring structures like, next slide, please. It could be bowel injury. It could be both vesicovaginal fistula and a uretrovaginal fistula together. So you need to keep off in your mind all the possibilities. Next slide. The CT urography. Next slide. Yeah, please play the CT scan. Next slide. So this was the video where after exploration, we found that the ureter is diseased and all necrotic. And when we started dissecting that area, it just gave away and there was an urinary leak. So there was an ureteric injury and a bladder injury in this patient. So this is a 37-year-old female who has history of continuous incontinence for 10 days, 2 to 3 pads per day. And there was LSCS, which was done in emergency and obstetric hysterectomy 20 days ago. So there was history of bleeding during the obstetric hysterectomy, which had required transfusion. In postoperative period, she was having postoperative fever, sepsis, and was in ileus. Next slide. Please show the CT scan. Next slide. Next slide, please. Next slide. Next slide. Next slide, please. So here we there was no excretion of contrast on the left side. on the CT scan. Next slide. And this, we did a PCN, and this was showing that the ureter was closed off. So she was managed by delayed surgery after 6 weeks ureteral neocystostomy. Next slide. This is an interesting case. I don't think anybody of you all must have seen it. And we have seen 2 cases like this. 26-year-old female who has undergone LACS. History of hematuria from day 1, which is gross and clots. Intraoperative course during surgery was uneventful as per the gynecologist. She had history of prior LACS also. And her previous LACS was uneventful. No history of any comorbidities, and she general and systemic examination was normal. Next slide. Kim Maman sir, I am coming to the point of placenta percreta and accreta. Please show the CT. Next slide. So here the CT scan, if you see, the arrow is pointing to the Foley's bulb, and you can see that the Foley's bulb is inside the uterus. It is not in the bladder, but you can see the Foley's bulb is inside the uterus. Next slide. So the perurethral Foley's catheter had gone in the uterus. Next slide. So this was an iatrogenic vesico-uterine fistula. Next slide. Yeah, please play. So cystoscopy, that's the ureteric orifice on both the sides. They are normal. And in midline, you can see, and we have passed the scope from the bladder to the uterus. And it is full of clots. So this is an iatrogenic vesico-uterine fistula. You have no other option but to go ahead and close it, which we did on the immediately following the cystoscopy. Next slide. Next video. Yeah, please play. So this is removing the sutures on the lower segment of the uterus. By the way, she had a bicornuate uterus. The bladder was sutured to the uterine wall. So instead of suturing the lower segment of the LACS to the lower segment of the, means the uterus to the uterus was sutured to the bladder. And there were lots of clots which were retained and had to be removed. So we opened the bladder and removed all the clots from the uterus. And then we realized that she had a bicornuate uterus. You can see that both the Higa's dilators are going parallel to each other. So then we close the lower uterine segment in 2 layers and close the bladder in 2 layers. Next slide. Bladder trauma. Well, bladder trauma, I'm sure you must have seen them by a dozen. They're very commonly seen, and I think they're the most common reason why urologists are being called in the gynec OT. And in our department, it has resulted in 1 marriage. So we are happy that the gynecologists keep on calling us. So it is it's rarely due to blunt trauma, but it is mainly associated with fracture pelvis in about 6 to 10%. And in penetrating trauma, it can be associated in, seen in 2%. And the problem about penetrating trauma is it can be associated with shock, and it has a mortality of relatively a higher mortality of 12%. Next slide. Bladder classification is by the 2002 consensus panel, which is divided into 4 groups. One is a contusion of the bladder, second is extraperitoneal rupture, intraperitoneal rupture, and combined rupture, combined intra and extraperitoneal rupture. Next slide. It is also classified as grade 1, 2, 3, 4, and 5, and grade 1 being an contusion or an intramural hematoma or a partial thickness injury. Grade 2 is extraperitoneal bladder laceration less than 2 centimeter. Grade 3 is more than 2 centimeter or an intraperitoneal bladder wall laceration less than 2 centimeter. Grade 4 is intraperitoneal laceration more than 2 centimeter, and grade 5 is both intra or extraperitoneal laceration extending to the bladder neck or involving the ureter. Next slide. Cystography has been used as a modality to diagnose bladder injury, but you need to be cautious about cystography that at times the bladder may be filled with clots and hence the outline may not be properly seen. The clots can be at times occluding the bladder perforation, and it'll give you a false sense that everything is normal. So when in doubt, it is always better to explore rather than leave it for the next day. Next slide. CT cystography is still a preferred method because you can come to know associated pelvic, visceral, bony injuries. You can differentiate it between a hematoma and urinoma. And a retrograde filling can be easily done. And you should not delay on a full bladder film on the delayed films of CT IVP because of shock or because of other problems related to hemodynamic situation, the bladder may not get completely filled, or there may be also false negative results. Next slide. Management of extraperitoneal bladder injury is very easy. If it is uncomplicated, you can just manage it by a urethral catheter drainage. A bigger size Foley should be used, and you should see that it is draining properly. And you can verify whether the healing has occurred after 14 days and remove the Foleys. Next slide. Occasionally, extravasation may persist for several additional days, but it usually resolves when it is extraperitoneal with continuous urethral drainage, and it needs to be confirmed by radiologically. Antimicrobial agent should be instituted on the day of injury and continued at least for a period of 1 week to prevent infections of the pelvic hematoma. Extraperitoneal blunt injuries warrant immediate open repair to prevent complications like fistula, abscess, and prolonged leakage in the presence of any complicating features. Next slide. So what are the indications for immediate repair? Is intraperitoneal injury, penetrating or iatrogenic non-urological injury, inadequate bladder drainage or clots in the urine, bladder neck injury, rectal and vaginal associated injury, open pelvic fracture. Sometimes we have seen during landslides that there was a young girl where the wall of her house had fallen on her, and her pubic symphysis had entered her bladder. So in addition to pelvic fracture would be an indication is fracture fragments inside the, that is sharp fragments of the fracture pelvis protruding or entering in the bladder. And selected stable patients where they are undergoing laparotomy for any other reason. Next slide. Intraperitoneal injuries or penetrating injuries should be managed by immediate postoperative repair. These injuries are larger than what you think so, And many a times we feel that we can manage them conservatively, but it's always better to go ahead and even have a negative exploration rather than sit on intraperitoneal injuries, because they are unlikely to heal spontaneously, and leakage of urine in the peritoneal cavity can cause peritonitis. It can cause rise in serum creatinine, and the patient very easily goes into sepsis. Next slide. When the bladder injuries are explored, it is necessary that you have to see that the ureteric orifices are properly inspected and their integrity is ensured either by cannulating them or by methylene blue or by indigo carmine. Any penetrating injuries involving the ureter or the intramural ureter warrants primary closure over a stent or reimplantation of the ureter. Drain should be always employed. Next slide. Now, placenta accreta, though I'm not sure how many of you keep on seeing these patients, but it is a very common feature. And I think every month there are at least 3 to 4 cases where we see placenta accreta and placenta percreta. Placenta and accreta is a condition where the placenta grows too deeply into the uterus, and it goes from your uterus into the bladder wall, and it may require it has a specific management protocol where you require serial USG. You will require to do an MR urography, and it requires preoperative embolization and intraoperative assistance by a urologist at the time of surgery. Next slide. There are 3 types of placenta accreta, placenta increta, and placenta percreta. Now, placenta percreta is the most dangerous type because it may involve the bladder or the intestines. Next slide. 32-year-old female G3P2L1, intraoperative call in view of bladder injury in a case of placenta percreta. So we have a series of placenta percreta, and majority of the times we have 2-3 observations which we have made are the MR urography and the ultrasound report doesn't match with the intraoperative findings. Either it is over-reported or under-reported. Preoperative embolization doesn't stop the bleeding in majority of cases, and hence you should be aware of methods of internal iliac artery ligation. So in spite of the embolization, you may have severe bleeding, and you cannot depend on the radiologist done embolization for control of bleeding. These are practically, we have seen these factors. Usually the bladder can be separated from the uterus. At the most, there is serosal injury on majority of times. At times, there is mucosal injury. We have not encountered ureteric injury. Though in one case, we had to do a partial cystectomy, and this was done because of repeated clot retentions in the postoperative period, and when we realized that part of the bladder had become necrotic. So this was re-explored, but on majority of times, it can be attended by simple separation of the bladder and the uterus, and at the most a few serosal sutures. Next slide. Can you go to one slide behind? So this is our protocol. We catheterize both the ureteric orifices, and we keep the ureteric catheters for 1 or 2 days. We always keep an SPC and Foley's catheter. So if everything goes on well in these patients, in the next 2 or 3 days, we remove the ureteric catheters. Foley's and SPC are kept for 14 days, after which the Foley's catheter is removed, followed by the SPC catheter. Next slide. So I thought I'll just show you that this is how we do it. G2P2 L1 placenta accreta with past history of bladder repair. Next slide. So again, I'm not sure because in emergency in gynec OT settings, photography is very difficult. And though it is in the mind to keep on documenting many times the residents and I suppose it doesn't happen. Documentation doesn't happen. So the pictures are not very clear. But this was a rent in the bladder wall, which was primarily closed. And we, as per our protocol, we always catheterize the ureteric orifices and keep a SPC and PUC. Next slide. All similar cases, but can't means like it's not very clear to people viewing it what exactly they are. But these are all cases of bladder trauma and cases of placenta accreta and accreta. Next slide. Next slide. So this is a patient who presented with a vaginal laceration. Very unfortunate 21-year-old female who underwent delivery in a primitive place near Mumbai. However, she presented to us with an episiotomy which was sutured. The urethra could not be delineated. The Foley's catheter which we have passed is coming back in the wound. The bladder and the vagina, both of them had lacerations. And in addition to that, she had separation of the symphysis pubis. Luckily, she did not have rectal injury. So that is her luck that only the bladder and the vagina were injured. Next slide. So intraoperative findings was a bladder rent of 8 centimeters and extending from the anterior bladder wall to the bladder neck into the proximal urethra. Anterior vaginal wall was also lacerated. Bilateral ureteric openings and trigone were not injured. And she had pubic diastasis for about 3 centimeters. Next slide. So these are a few of her operative films where here we are trying to show you the vaginal laceration. Next slide. So you can see the gloved finger. This is an intraoperative picture from the suprapubic region, where you can see that a finger is visible in the pelvic cavity, anterior vaginal wall, and the bladder. So both of them are lacerated, or there is both of them are opening into one cavity-like structure. Next slide. So we did a bladder neck repair and vesicourethral anastomosis and the bladder and the vaginal wall separately, and external pelvic fixation for her pubic diastasis. Next slide. Yeah, next slide. But luckily, God is kind. After some days, at least he was kind to her, and then she had no VVF in spite of all these surgeries and everything, and she is doing well. Next slide. So come to the almost last part of my talk, penile fractures. It is a disruption of the tunica albuginea with the rupture of the corpora cavernosa. Fracture typically occurs during vigorous sexual intercourse when the rigid penis strikes against the perineum or the pubic bone or any other neighboring structure and produces a buckling injury. The diagnosis can be made reliably by history and physical examination. Next slide. The patients describe a crackling or popping sound as the tunica tears, followed by pain, rapid detumescence, and discoloration and swelling of the penile shaft. If the Buck's fascia remains intact, the penile hematoma remains contained between the skin and the tunica, resulting in typical eggplant deformity. If the Buck's fascia is disrupted, then the hematoma can extend to the scrotum, perineum, and the suprapubic region. Next slide. Self-inflicted injury can also be one of the differential diagnoses of a penile fracture. Multiple contemporary publications recommend that suspected penile fracture be promptly explored and surgically repaired. However, all of us must have noticed, and it's commonly seen that many times patients present at a do not present immediately and come after a period of 7 days, 8 days. So whenever they present, they need to be explored. Next slide. Next slide. So this is a 40-year-old patient, and this is his penis. Next slide. And in addition to the corporal tear, he had a urethral injury of approximately 3 centimeters. So we did primary closure of the urethra over a Foley's catheter and repaired his fracture penis. Next slide. Next slide. Yeah, so open repair with primary suturing of the urethra was done. Next slide. 24-year-old patient presented with sudden detumescence and a pop sound during sexual intercourse. Next slide. So this is the typical eggplant deformity. Eggplant, as you know, is what we call as bangan, and being purple in color and having this peculiar shape. That's why I suppose it's eggplant deformity. Next slide. Next slide. So here you can see that the scrotum is also showing the hematoma. Next slide. Yeah, next slide. So you can see that the corporal tear is almost involving the entire circumference of the corpora in this patient. And primary suturing of the corpora is all that is required. Next slide. Next slide, please. Urethral injuries. So in urethral injuries, I will be only covering the acute part of management. I won't be covering delayed management of urethral injuries. Next slide. So this is a case of a young woman who underwent delivery elsewhere. You can see the episiotomy being sutured. You can see that the urethra is not in its position, and there is a vertical tear on the dorsal aspect of the urethra extending up to the clitoris. So her entire urethra was avulsed from the puboprostatic ligaments, and the attachments to the symphysis pubis were avulsed and the urethra was pulled down. Next slide. So here this photograph, you can clearly see that there is a huge tunnel above the urethra, and it is extending up to the clitoris. So in succession, we had 2 patients of similar type. Next slide. Yeah, please play the video. So all we did was give a proper wash, remove all the clots and debris, and suture it in 2 layers. And both the patients did very well. This patient had a very big episiotomy. The second patient, you can see that it is different from the first case. This episiotomy is almost extending up to the perineum. Next slide. This is again a case of urethral trauma. Next slide. So the DRU which is shown is not of an acute patient. It is only it is a representative retrograde urethrogram of a patient with pelvic fracture urethral distraction defect. But I suppose we all are conversant with the methodology in which we should do a DRU during acute urethral trauma. What are the indications of catheterization? How should a catheterization be done in the acute setting? And I will be briefly discussing the management options of acute urethral injury associated with fracture pelvis. Next slide. So an immediate concern in a patient with pelvic fracture urethral distraction defect is ABC, that is airway, breathing, and circulation. Then other secondary goals are, so primary goals are, first is preservation of life and taking care of ABC. Second is diversion of urine in any manner which is possible. And the secondary goals are preserving the sphincter, preserving sexual function residual to trauma. So these are not primary goals. Primary goals being airway, breathing, circulation, and diversion of urine. Next slide. Imaging techniques which can be utilized are a pelvic X-ray, abdominal and pelvic ultrasonography, retrograde urethrography, abdominal and pelvic CT scan, and a pelvic MRI. But as we know that abdominal and pelvic CT scan is the best modality to evaluate the extent of pelvic fracture, the amount of bladder injury, presence of any bony fragments if present, the presence of associated abdominal injuries, any intraperitoneal bladder injury, any collections, any expanding hematoma, any hematoma in the pelvic floor or in relation to the pelvic side walls. Next slide. MRI does provide additional information of the lateral displacement of the prostate and the severity of the posterior urethral defect. But the time taken for an MRI circumvents its advantage in this acute situation. It has an additional advantage of detecting bony fragments between the two ends of the urethra in a pelvic fracture. An MRI in conjunction with an RGO and an MCRG is ideal, but it is not only the sole method of evaluation. And the utility is because of the time taken for this investigation. Then there is a role of flexible cystoscopy. Next slide. For cystoscopy, the problems which are there is, can lithotomy be given? And what can happen in addition if the vascularity is compromised due to the pelvic fracture? Next slide. So emergency treatment of posterior urethral trauma ideally is suprapubic urinary diversion. The second option being endoscopic urethral realignment and delayed urethroplasty after a period of 4 to 6 weeks or 3 months. Next slide. You also need to know the mechanisms for the pelvic fracture urethral distraction defect as a part of in exams. Next slide. Now, the timing for urethral repair of urethral injury is ideally 3 months from the time of injury, because this allows all the tissues, the inflammation, hematoma, and everything to settle down, and the tissues are back to their normal consistency and vascularity, so that surgery which is done can be easily, the tissue holding is easy and suturing is easy, and the tissues are able to hold the sutures. Next slide. That is the reason for, so immediate options is railroading, though it is described as a method I think there are only certain centers which are following this method of railroading. Initially, it was done blindly by using modified urethral sounds, and recently it can be, means the use of flexible cystoscopes can be combined instead of using urethral sounds, but I have never done this surgery. So for me also it is theory. Next slide. Now, primary repair is also described as a modality, and it main indications of primary repair being penetrating injury, injuries of the which are involving the bladder, neck, and prostate, injuries involving perineal degloving, and injuries associated with rectal tear. Next slide. So, I think I have tried and covered majority of the topics. I hope all of you are not sleeping. At least some of you are listening. And I thank USI and ISU for the opportunity given to me for conducting this session. I know it can be very difficult to pay attention to anybody beyond. For me, at least the time limit to pay attention to any lecture is not more than 8 minutes. So I don't know how you have tolerated me for more than 1 hour. Thank you for patient listening, and thank you for the opportunity. I'm open to take up a few questions.
Madam,
But
excellent presentation. The excellent presentation, Madam Arvind here.
Thanks.
Excellent presentation, covered everything. I have, and as usual, the photographs and the images were absolutely great. What I wanted to ask you, Madam, you have got certain patients of having pelvic fracture in females with urethral injury. In these patients, did you have to do a colostomy as well with the repair, or you were able to manage?
Arvind, we had only one patient who presented with extensive trauma following delivery of that dead fetus. And she had this, as I told you, she had pubic diastasis. She had no rectal injury, no injury, luckily, to the bowel part at all. Only when we opened the bladder suprapubically, we found that the vagina and the bladder are opening in the same cavity. So all we had to do was to separate these two to their respective places, and her urethra was avulsed, so it had to a primary vesicourethral anastomosis had to be done, and the external fixator was put to bring her symphysis pubis back to position. So this was the only one patient where I have seen a female urethral injury along with bladder injury in an acute setting. And one more child I have done where the wall had collapsed on her, and we had a very nice video. We didn't operate her in an acute setting, but unfortunately the videos, as you know, in any department get lost, and it's very difficult to keep track of residents and videos. Though I'm very unhappy about the fact that this video is lost, because in her pelvic symphysis had protruded into her bladder, and there was injury to the bladder. So these are the only two cases I encountered. Maybe you have seen a few and you could.
Oh man, we haven't. This is. I think your experience is unique. This is number of cases which you have, and the variety, particularly of obstetric trauma and pelvic fracture with bladder injury in females, is quite unique. One more thing, one more question I had is when you did a bladder neck repair, primary bladder neck repair in these patients compared to a delayed repair, are the results better with the primary repair? Because it should be so. I just want to ask you, because you have got excellent so many cases.
No, see, in the rest of the two urethral injuries, the urethra was intact. Only I do not know why the urethra was avulsed from its attachment to the pubic symphysis, and it was drawn down into the vaginal cavity. So there, all we had to do is take a few sutures of the soft tissue and put the urethra back in its position, and to the vagina, to the mucosa there. And in this pelvic fracture, we had no other option because if you had seen that picture, the Foley's catheter which we had put was coming out back in the perineum. So all we did, hoping that it will heal, was to repair the put a few sutures between the urethra and the bladder neck. And
Arvind,
it has been just
Arvind,
God's grace that she
Sir.
has healed. So I don't think we did anything great.
Arvind,
Sir, tell me, sir.
Arvind, I think Dr. Sujata, if you can make the information on this platform about the 4th December cadaver workshop, and
Sure,
Navneet
sir.
can put the link on the chat section only for the resident to register,
Yeah.
and he can put the brochure here also. Arvind, and after that, madam, you can continue discussion with ma'am.
I
Nice,
think
sir,
it's
we
an
have come
excellent
to the
question.
end of our you have
Yeah.
come to the
No,
end of our
I was there
session.
only. I was enjoying the whole
Yeah.
presentation. Yeah.
Okay,
Yeah.
sir. Yeah, thanks a
Sir,
lot, sir.
Madam, that excellent presentation. It was very, very descriptive, and everybody is appreciating. There are really no questions because it's so well described. Thank you so much.
Yes.
We were
Yeah.
really grateful and honored to have you here on this platform. Thank you again, madam.
Thanks, Arvind. Thanks for those kind words, and thank you,
Yeah.
Chawla, sir, for giving this
Thank you, ma'am.
opportunity.
Thank you, Arvind.
And
Thank
I'll
you.
just make
Thank
that
you, sir.
announcement that on December 4th, we are having a cadaver workshop in KM Hospital on the 8th floor. And this has 4 modules. The first part would involve bowel in urology, where we will teach you techniques of how to do an ileal ureter, how to make an ileal conduit, the stoma part. And we will demonstrate the Struder's pouch for you and try and do an Indiana pouch. So this would be the first module. The second module would be nephrectomy, followed by reimplantation of that kidney in the iliac fossa, where you would have hands-on vascular techniques can be learned. The third would be demonstration of lymph node dissection templates, RPLND, then bladder, the inguinal group of lymph nodes and iliac group of lymph nodes. So these three templates will be done, and Dr. Pankaj Joshi would be coming for the urethral part, where he will demonstrate end-to-end urethroplasty, buccal mucosa. Obviously, we are not going to take the cadaver's buccal mucosa, but some substitute, and you would know the techniques for buccal mucosal onlay and inlay urethroplasty, and followed by penile implant prosthesis. This will be the semi-rigid, the rigid penile prosthesis, not the
Shah's process.
inflatable Shah's prosthesis. And so these 4 templates will be covered. There will be 4 students in each module. There will be 2 cadavers. So there will be 8 students for each module. And beyond, so that they should have an exact hands-on experience. We are not taking more students. So please do register and come in advance. And the videos and the links and the study material will be sent to you one day in advance. And we would expect you, so you go through the videos so that it will be easy for us to teach you, and it will be easy for you to learn the techniques. Sir, would you like to add anything, sir?
No, ma'am. Yeah,
registration?
Yeah, registration. I think the link will be put here. It is there already in the group, and Navneet is circulating by mail. If you have not got any brochure, or if you know information, you can write to us. You can write to central office. You can write to me or madam. But we are circulating in all WhatsApp. But again, the main point is limited registration. It's because it's hands-on. We just take your hand and make you do. So the limited slots are there. So better is to first come, first serve, and just fill the registration form if you're interested. Yeah.
Okay, sir. So I
Okay, ma'am.
suppose we
Arvind,
have
thank you very much.
finished a little. Yeah, thank you, Arvind, and thank you, Chawla, sir. Thank you, everyone, for listening patiently. Bye.